The OPTIC study is investigating ponatinib at different starting doses. And the reason for this is ponatinib is a third-generation TKI, and it had demonstrated very significant activity in patients that had received multiple prior TKIs or who had a mutation T315I. With a major cytogenetic response rates of nearly 70%. Across the board, T359 mutated patients, other mutations, non-mutations, et cetera. And these are in patients that had received 95% of them had received 2 or more TKI. So efficacy-wise, very good. But then we realized that there were some patients that were having arterio-occlusive events with a variable rate, depending on how you define it, but somewhere between 20 to 30% of patients. And there was some suggestion that perhaps the dose had some correlation with the incidence of these events. And actually, many physicians started using a lower starting dose than the standard, which is 45 milligrams daily. So with that, we decided to investigate prospectively whether a lower starting dose would maintain the efficacy, because we like that part, but reduce the safety concerns with reduce the incidence, particularly of the arterio-occlusive events, to a level that would be more acceptable. The design was that patients, this included only patients with CML in chronic phase, adults, and they should have received and be resistant or intolerant to at least 2 prior TKIs or had the mutation T315I. And they were randomized 1:1:1 to 1 of 3 starting doses, 45 milligrams, which is the standard, 30 milligrams, or 15 milligrams. The primary endpoint of the study was to achieve transcript levels of 1% or less at 12 months. And an important component of the design was that patients who achieved that response had a mandatory dose reduction to 15 milligrams daily. Another important element of the design is that every arterio-occlusive event that was reported by the investigators was reviewed prospectively and in a blinded fashion, meaning without knowing the dose that the patient was receiving, by a panel of, by an independent panel of cardiologists, neurologists, and vascular experts to assess whether these met the criteria of arterio-occlusive events according to the American Heart Association and the American College of Cardiologists. Well, first, in terms of efficacy, the starting dose of 45 milligrams, the standard, was significantly more effective than the lower doses. The rate of transcript levels of 1% or less at 12 months, again, that was the primary endpoint, was 44% with the 45 milligram starting dose, compared to only 29% with the 30 milligrams and 23% with 15 milligrams. And we also saw that patients that had the highest risk features had the greatest benefit. For example, patients with T315I mutation, the response rate was 60% if they took 45 milligrams, but only 25% if they took 30 milligrams, and even lower at 15 milligrams. Patients that had not achieved a cytogenetic response with the prior therapy, which was 60% of the patient population, also had a significant benefit, 50% response rate with 45 milligrams, only 21% with 30 milligrams. So the highest risk feature patients benefited the most. The other important finding then about the safety, the incidence of arterio-occlusive events, is 2 important things that we found. One is that the overall incidence of these events was fairly low compared to what we had seen in PACE. The 45 milligram cohort was 9.6%, whereas the 30 milligram was 5.3%. And 2 is that difference was very small from 45 milligrams to 30 milligrams. So there was a bit of a drop, but the difference was much smaller in terms of safety than the very large difference that I described in terms of efficacy in favor of the 45 milligram daily dose. Well, I think that our conclusion is that the dose of 45 milligram starting provides the greatest benefit risk ratio for these patients that have failed multiple prior TKIs. So the impact in practice is, number one, that is the standard dose, that is the dose that we should use, and it's particularly important for patients that have high-risk features for the disease, again, T359, multiple prior TKIs, etc. But also very important is that this is the first study ever with a TKI that uses a response-directed dose adjustment, dose reduction. And that dose reduction, once the patient achieves the response, greatly benefits and reduces the risk of arteriocclusive events. That is a very important finding that's made it into the label and even opens the question whether we should be investigating this approach with other TKIs as well. Well, one important thing to remember is that in addition to the proper management of the drug and the dose, is the management of the comorbidities. These patients frequently have comorbidities, and the aggressive management of their hypertension, the diabetes, their hypercholesterolemia, whatever, is very critical to ensure that the patients have the best possible outcome and that we don't negate the potential benefit of giving them a drug that is very effective. Because after all, the greatest risk that these patients face is the leukemia. So we need to make sure that we give them the best treatment possible.